Welcome everyone to the 6th annual Anne Klibanski Visiting Lecture. My name is Louisa Sylvia. I'm the Director of the Office of Women's Careers and the Center for Faculty Development. It's my distinct pleasure to welcome Drs. Erica Warner and Victoria Mango, who will be speaking with us today on cancer health disparities, opportunities, and challenges. For those who have not attended one of our lectures before, we like to give a little bit of a background on our scholars and what the award entails. As many of you may know, during COVID, it has disproportionately affected women in the sense that women have had to pick up additional childcare and household responsibilities. As a result, have had challenges with keeping up with their careers and in particular giving talks. And so this virtual setting has really made it much more convenient to do visiting professorships such that people can give talks at different institutions virtually. So we've awarded 36 women faculty, the clinicians, educators, and researchers, as well as postdocs, who've shown exceptional promise as leaders in the field and who would benefit from this opportunity to have speaking engagements, mentoring, as well as networking opportunities. Again, the virtual visiting professorship is really a distinct opportunity to be able to do national and international talks that are organized by the Center for Faculty Development. This award is named after Anne Klibanski, who has been really a leader in so many ways, but particularly in the mentoring of our faculty and trainees at Mass General. She was the former director. She's currently the president and CEO, and she's the former director of the CFD, former head of the neuroendocrine unit, and she's had leadership roles at the Harvard Catalyst, NIH, Endocrine Society, and she's just been extremely successful both as a researcher and as an advocate and supporter for women. And for those of you who don't know, she did establish the Claflin Awards. And if you're not familiar with those please check out our website and learn more about the Claflin Awards. They're great opportunities to support women faculty here at Mass General. So these are our Anne Klibanski Visiting Scholars who have the Scholar Award, and down at the bottom there, you'll see Dr. Erica Warner, who'll be speaking today. And these are our partnering organizations and institutions who are working with us to give the opportunity of the visiting professorship to these wonderful faculty. And today we have Dr. Mango from Memorial Sloan Kettering Cancer Center. So again, then we have the lecture series in particular, which is, again, this great opportunity for people to give talks abroad, but in a virtual setting. And you'll see the talk there in the flyer that we're having this afternoon. And then we also have another talk next Tuesday on the 18th. Please tell people about these wonderful opportunities to support our women faculty and trainees. They're great talks and they're great ways to support our women faculty. So with that, I'm going to introduce Dr. Erica Warner. She's going to be talking about COVID-19 cancer health disparities. She's assistant professor in medicine at Harvard Medical School. She got her PsyD from the Harvard Chan School of Public Health, and her research has really been focused on lifestyle and behavioral and genetic factors affecting cancer screening and intermediate markers of cancer risk and survival, with an interest in molecular subtypes and racial and ethnic and socioeconomic health disparities. So very timely, very important talk today. I look forward to hearing from Dr. Warner about that. She's going to go after Dr. Victoria Mango, who's going to give a talk on bridging breast cancer imaging disparities through technological innovation and global opportunities and challenges. She's the associate attending radiologist at Memorial Sloan Kettering, the co-director of the Breast Imaging Education and Training Center. She got her MD from New York Medical College, and her research focuses on developing and evaluating novel approaches to breast cancer imaging with an emphasis on global clinical impact and resource efficiency. So two wonderful talks today. I'm going to stop sharing and pass the baton over to Dr. Mango.
Thank you so much for that kind introduction. I'm really pleased to be here. It's a wonderful program that you have. Can you just confirm if you can see my slides okay?
Yep.
Okay, great. So today I'm going to be focusing on breast cancer imaging disparities. I'm a radiologist specializing in breast imaging, and I'm going to look at how we've been using technological innovations to try and bridge gaps abroad and some of the challenges that have been associated with that. These are my disclosures. So I'll start with a general overview of breast cancer disparities and then look at some specific programs I'm involved with in India, Nigeria, and Kenya, And then I want to close with just a few minutes talking about how we're using artificial intelligence in these settings to bridge global cancer disparities abroad. So, as many of you are familiar with, the World Bank divides countries by gross national income per capita. So, the United States and much of Europe considered high income countries. Today, I'm going to be focusing on low income and lower middle income countries, both in Africa and in Asia. And this certainly translates to healthcare expenditures per capita compared to the United States, where it's over $10,000. Places like Nigeria and Kenya and Uganda, it's a small fraction of those healthcare expenditure dollars. So, what does that look like for cancer in low and middle income countries? Well, although communicable diseases are still responsible for most mortality in these areas, when we look at cancer and cancer related deaths, about 70% of global cancer deaths are occurring in low and middle income countries, and the incidence of cancers are rapidly rising. So, my personal focus is on breast cancer. In low and middle income countries, the incidence is increasing about 5% per year. This is attributed to increasing life expectancy and also the quote unquote westernization of lifestyle there. And we see that breast cancer is the leading cause of female cancer deaths in low and middle income countries. So I'm very privileged to work at Memorial Sloan Kettering Cancer Center, where we have lots of resources. We have plenty of mammography units, ultrasound machines, staff to help us see patients. And I would love to be able to take that exact same practice setting and apply it to anywhere in the world. But unfortunately, the resources just aren't there. And so we take a resource stratified approach. Dr. Anderson from the Breast Health Global Initiative has published on what that might look like. So from the very basics, where there may not be any breast imaging, no mammography or ultrasound, and really the diagnosis of breast cancer is based on clinical breast exam and perhaps a biopsy done under palpation. And then we can move up to more and more resources, to using imaging in a diagnostic capacity, eventually for screening, and then image-guided biopsy. So there are multiple ways in which radiology helps along this tiered approach or research stratified approach to breast cancer. So when we think about radiology in low and middle income countries, it's estimated that 2/3 of the world has no or insufficient radiology services. And this has a huge impact on both diagnosis and treatment, certainly for cancer, but other diseases as well. And so I'm fortunate to work with several different groups that are looking to address these disparities worldwide. So at Memorial Sloan Kettering, we have a global cancer disparities program. With this group, we focus on work predominantly in Nigeria, some in Kenya as well. I also co-chair the Society of Breast Imaging, has an international education outreach committee where we do various educational initiatives around the world. And then I also work with a group called RadAid International. And so for those of you who aren't familiar with this organization, this is a nonprofit that seeks to bring radiology to low resource areas. And this comes through education, equipment donations, infrastructure, and other forms of support. This is meant to be a real platform for radiology capacity building, and it's very much an interdisciplinary collaborative effort. So we have about 13,000 volunteers, and it's not just radiologists like myself, but it's also technologists and radiology nurses and informaticists and IT groups. So everything that's involved with effectively delivering radiology care is involved with this approach to radiology outreach. And so this is a map showing all of the RadAid sites. I work primarily in Nigeria with the MSK group. I'm director of our RadAid Kenya program, so my RadAid work has focused in Kenya, and then I've also done some work in India as well. So I'd like to take the bulk of my time to talk about the different breast cancer disparities we've looked to address in these countries. So in India, we've worked with a mobile women's healthcare outreach program. This is based in Chandigarh in the northern part of the country. This is called Asha Jyoti, which means ray of hope in Hindi. And this has been a real collaborative effort between PGI, the medical institute there, RadAid, and Philips healthcare. And what this is it's a mobile van that brings screening services to the community. And we focus on diseases predominantly affecting women: breast cancer, cervical cancer, and osteoporosis. So it's a way for women to come and get screened for all three of these diseases at one stop. And there's an extensive network to facilitate any additional testing, follow-up, or treatment for these women. So we call it a van, but this is actually what it looks like. It's a truck. And so we're able to drive this to communities in need. This is what the waiting area looks like, with women waiting inside. And then they're able to go in and be screened privately. This is what it looks like. The truck inside is divided into smaller private rooms. There is a mammography unit, DEXA screening. This is where we do the cervical cancer screening. And then there is a portable breast ultrasound. Many challenges in getting something like this going. Mammography, there's some data about its utility depending on the resources of the community that you're interacting with. Here, for example, when the van was first designed, they realized that the lead shielding required, because mammography uses X-ray, would be too heavy for the tires of the truck. So things that you might not think about initially come up in designing something like this. From a radiology perspective, we typically do not allow two imaging modalities to be in one room. Here we have our DEXA scanner right next to the mammography unit because of space restrictions. Only one patient is imaged at a time, but this required some special approvals. As well as in India, it sounds like a great idea having a portable ultrasound unit. In India, that is extremely difficult. Portable ultrasound is often not legally allowed because of issues of female infanticide, meaning they don't want women who are pregnant to undergo an ultrasound and find out the sex of the child in advance, because there have been significant fetal demise related to that. So getting the ultrasound unit, even just to legally be able to have it on the van, was quite a challenge. And so this is how the network works for women visiting the mobile clinic. There's first community liaison involved to make sure women are educated and that we're doing this in a culturally appropriate way. Once women are screened, we have to make sure that they can reliably get their results. And then if any additional testing, diagnosis, or treatment is necessary, making sure that they have a way to obtain that and pay for it. So we always want to make sure we're screening in a responsible way, that if any cancer is found, that we are able to diagnose and treat it afterwards. And so this program began in April 2012 and has now screened approximately 15,000 women. My role as a radiologist here involves consultation, working with the radiologist. This is Dr. Talika Singh, one of the radiologists heading the program in India. She and I have worked together both in India and in the United States. She has traveled to work with me here, and it's really been a wonderful mentoring and exchange. I feel like I've learned just as much from radiologists abroad as I've been able to teach them. We do a lot of lectures and case conferences, and particularly in the setting of COVID, a lot of our international outreach has been educational over Zoom. We also look a lot at mammography quality improvement and mammography training. So this has to be a part of any radiology equipment donation, obviously making sure that your technologists are able to use it and you have the radiologist capacity to read the images. Here, our wonderful volunteers through RadAid created a 40-hour curriculum for their technologists to learn mammography. And I just want to talk a minute about why that's so important. On the left here, this is an example of a standard mammographic image, not showing any breast cancer, but the radiologists point out that this is an inadequate image. In order to call this an adequate mammogram, I need to see some of the patient's pectoralis muscle and some of the inframammary fold. The last thing we want to do is falsely reassure them, saying their mammogram is normal, when in fact she was called back for a better mammogram picture. Here I can see pectoralis muscle in the corner. We can see there is a small invasive ductal cancer and the posterior aspect of the breast. So this is very deep, close to the chest wall, and we could see it on her MRI as well. But these are exactly the types of cancers we want to find with screening. It's a small, invasive, node-negative cancer, very highly treatable. And so the quality of the mammography image, and a lot of that is dictated by our technologists, is so important. So part of what we do is not just the education, but looking qualitatively and quantitatively, does our education actually help with breast imaging quality? So here I led a study reviewing the Asha Jyoti mammogram cases, the ones that were done on that mobile van before their training, immediately after the training, and then most recently. And what we saw, as you might expect, is that the education did significantly improve the image quality right after the training, but that improvement is not sustained 6 months later. And so, like we all notice from our daily experience, that there is a benefit of ongoing education. This is just a picture as a working mom doing international outreach. I often bring the kids along. So this is my daughter in India. Sometimes the jet lag can work to your advantage if they're going to fall asleep. The next country I want to talk about is Nigeria. A lot of our work at Memorial Sloan Kettering focuses in Nigeria. Here we see disproportionately higher mortality rates from breast cancer with overall 5-year survival less than 25%. You can compare that to 90% survival in the United States. And here breast cancer incidence is certainly increasing. And there's a large disparity in how breast cancer presents. So in Nigeria, over 80% of the cases present as stage 3 or 4, much more advanced stages, harder to treat, and when cure is much less likely. So in Nigeria with breast imaging, we focused a lot on ultrasound. So I talked about how in India, mammography comes with its own challenges as an X-ray based technique. With ultrasound, we're using sound, so we don't have those same safety considerations that you do with X-ray. This is kind of your typical unit, which theoretically is portable. It's on wheels, but it's certainly very bulky. You have to be able to plug it in to a consistent power source. And so multiple vendors have developed these highly portable ultrasound probes. You can download an app to a smartphone or a tablet, and there you have a very high quality ultrasound machine. So I've been able to travel to Africa with 3 or 4 of these in my backpack, and it certainly makes doing mobile health outreach in radiology much more feasible. My colleague, Dr. Sutton, along with Dr. Amnisor in Nigeria, have led a project we've been working on in terms of teaching Nigerian radiologists how to perform image-guided breast biopsies. And this has involved doing a blended learning program followed by simulation biopsies and then eventually patient biopsies. And so we've traveled to Nigeria multiple times, but with COVID, this slowed things down some. We had to expand to a more e-learning component. This is Dr. Deji, who spent time with us at Memorial Sloan Kettering learning in person, as well as another radiologist from Nigeria. And that allowed us to do a lot of the supervision remotely. So myself and my colleagues, we dialed in at 3 o'clock in the morning in New York, and we were able to, through a bunch of iPads set up around the room, watch and give advice on some problematic biopsy cases. But again, we had 2 Nigerian radiologists that had spent a lot of time with us at Memorial Sloan Kettering in New York. And so they were able to ensure patient safety and provide supervision on site as well. And so this has really been capacity building, a train the trainer model where we're teaching Nigerian radiologists, and each of them are training several other radiologists on how to do these biopsies. The other technological advancement that we've been working on in Nigeria is something called the iBreast exam. So this is a highly portable handheld device that has these pressure sensors, almost like the pads on your finger, that allow you to electronically palpate the breast. And this is particularly important in settings where imaging is a very limited resource, and so where you're relying on clinical breast exam to appropriately triage patients who should have imaging. Now, a trained clinical breast exam is certainly not always available. Women can't always get to a trained healthcare professional for that. And so the IBE is meant to be used by community health workers with minimal training. And so what it does is it assesses for findings that warrant further evaluation. It's not going to tell you something is cancer or not, but the sensors will tell you if one area of the breast is perhaps firmer than another and there might be a mass underneath. And the output is very easy. It's not like interpreting a mammogram image, for example. So on the top is a normal IBA output. On the bottom, you can see this red spot in the right breast. That's an area of concern where a patient should get additional imaging workup. And so we received a grant from the Prevent Cancer Foundation. This is Dr. Lacan, an experienced breast surgeon in Nigeria, and the nursing team there. Here we did a pilot study of 424 women, all of whom underwent that eye breast exam, a clinical breast exam, a mammogram, and an ultrasound. We recruited patients through multiple ways, and we also did some knowledge assessment. So it's not just about bringing patients in to participate in an imaging study, but we also wanted to get a sense of what is their knowledge of breast cancer so that we can help inform future patient-based educational initiatives. So most of these patients had heard of breast cancer. These are all known risk factors for breast cancer, and we saw a wide variety in the percentage of patients that were aware of these different breast cancer risks. We also found that there were a lot of misconceptions about breast cancer. So a significant number, over 60%, thought that putting the phone in their bra or money in their bra would increase their risk of breast cancer. And half of them thought that wearing a bra all the time would increase their risk of breast cancer. So this is very eye-opening and can help us tailor educational efforts directed at some of the misconceptions in the community. So what did we find? Looking at the eye breast compared to the clinical breast exam, when we look at any breast finding, meaning that the imaging showed something there, maybe a cyst, maybe a cancer, maybe a benign fibroadenoma, we found that the IBE showed better sensitivity to CBE and that they had similar negative predictive values. When we looked at that in a more refined way, meaning imaging showed something that warranted biopsy, the sensitivity and negative predictive values were the same, but the specificity of the IBE was very low. And so this is very important when you think about a resource restricted area. We certainly don't want a lot of false positives resulting in a lot of women needing a workup. So we've been working on multiple modifications with the vendor to improve the specificity. In this in this study, we did find 15 cancers. IB and CB actually both missed the same 2 cancers, less than 2-centimeter masses. And so here we're now looking at analyzing the technology with community health workers, improving the specificity, and looking at IBE as a breast exam teaching tool. The last country I want to talk about is Kenya, with a population of about 47 million. They have less than 200 radiologists total, but fortunately they do have 3 radiology residency programs now in the country, and those are the primary hospitals that we work with. This is Dr. Ndumia, one of the radiologists in Nairobi, who is breast imaging fellowship trained. In the entire country, there are only 2 fellowship trained breast imagers, and comparing that to Memorial Sloan Kettering, there are 35 of us. So just at our one institution, we have that many more than the entire country. So we were involved in hosting the first dedicated breast imaging symposium in Kenya, where we had 100 people attend, again, using this highly portable mobile ultrasound technology and phantoms to teach hands-on biopsy skills. And so I want to focus, there are many hospitals that we work with in Kenya, but the main work has been at Aga Khan and University of Nairobi, both of which are located in Nairobi, Kenya. So Aga Khan is a private, not-for-profit hospital. They're relatively well-resourced for the area. This is their department, and it's really been a wonderful collaborative effort with their group. We work in various areas of education. So we've had 5 formal educational symposia focusing on breast cancer. And again, using this highly portable technology, we're able to teach some hands-on breast imaging skills during these workshops. In terms of education, we also work with Dr. Ndumia and her residents. She is the program residency director there. In terms of clinical work, we've donated multiple QC phantoms to help with mammography quality control. They do have breast MRI capabilities, so we've been working on MR biopsy skills, and they now have vacuum-assisted biopsy as well. For research, we've been looking at getting targeted evidence from the local population. So a lot of our publications in breast imaging are based on women from the United States or Europe, really trying to get local data to better understand the landscape of disease, looking at artificial intelligence, and then also providing mentorship for grant writing and abstract and manuscript preparation. And then one of the most rewarding areas that we focus on as well are these breast outreach camps. This was actually my first opportunity to get a Kenyan medical license. So I was able to practice medicine there. This was in 2 days screening 450 women. So it was really all hands on deck while we were there. And this is an example from that outreach camp. And then just briefly at the University of Nairobi, my colleague through RADAID, Dr. Dixon, has started the first interventional radiology fellowship. And right now I'm very much involved in a PACS donation, which is in progress for the University of Nairobi. So with my last few minutes, I just wanted to talk about the role of artificial intelligence. Radiology is really one of the most applicable areas for AI. We have a lot of mineable data from clinical image data sets, and there are many, many publications looking at AI in breast imaging in various forms along our imaging pathway for patients. We've focused a lot on breast ultrasound as that's a modality that can be used more readily in low and middle income countries. Looking at decreasing BI-RADS3 utilization, this is where we recommend patients come back for a 6-month follow-up, which may not be practical in the settings we're talking about. How to improve our benign biopsy rates and also our inter and intra-observer variability. So we work with a system called KIOS Decision Support for the breast. This is an example of a small invasive ductal cancer on ultrasound. And so this box indicates the region of interest and the AI indicates a likelihood of malignancy. So it can help appropriately determine which patients should undergo image-guided biopsy. And so we looked at this with 15 readers and we found that 14 out of the 15 did better, had a better AUC when they were looking at ultrasound images with decision support, so with the AI, rather than looking at ultrasound images alone. And we also saw improved inter and intra-observer variability. Now that was retrospective data. We've also looked at prospective data. This is from a private practice group in New York. This dashed line showing when AI was implemented. We saw that their biopsy rate stayed the same, but the benign biopsy rate went down and their positive predictive value went up. Now this is in a real clinical environment, so it's hard to control for multiple factors the way you can in a retrospective study, but it certainly points to the AI helping with clinical decision making. Now, in low and middle income countries, AI has tremendous potential to maybe bring radiology services to patients with few radiologists. So this can come in multiple forms, and we're really focusing on this because the inequitable use of AI really has the potential to further widen radiology-related healthcare disparities. So I don't have time to go into all of these, but numerous AI developers have partnered with RADAID to bring their software to these settings. And AI in low and middle income countries definitely proceeds differently than it does in high income settings. This publication with Dr. Malora last year, we were able to describe that this involves not just implementing AI, but also a lot of attention to clinical education, infrastructure deployment, and phased AI introduction. All of this involves a lot of ethical and legal considerations, so we want to make sure we're appropriately allocating scarce medical resources and really think carefully about data usage, storage, and anonymization. And this is something that the United Nations has highlighted, that low and middle income countries are in danger of providing this raw data that's then producing digital intelligence that they subsequently have to pay for. So that's something that we certainly keep in mind. RADAID has recently developed something called the Friendship Data Trust. This is a way for multiple resource-poor health institutions to combine their anonymized data to a not-for-profit collective. This gives them collective leverage to interact with AI developers. And so this is one way we're looking to address this inequality. So in conclusion, there are a lot of disparities in breast cancer screening, diagnosis, and treatment, but a thoughtful collaborative approach is really essential to bridge these gaps. And hopefully through engaging with technological advances, we can bridge gaps and more rapidly decrease disparities. And so with that, I want to thank my wonderful colleagues at Memorial Sloan Kettering, my chairwoman, Dr. Resac, as well as all the wonderful volunteers through RADAID and the MSK Disparities group who contributed to the work that I discussed. And so with that, I thank you very much. And I'll give you Erica Warner to talk about COVID-19 and health cancer disparities.
Thank you so much, Dr. Mango, for that fantastic presentation. Give me a second to share my screen. Okay, so I'm going to be talking about COVID-19 and cancer health disparities. Dr. Mango had a global focus. I'm going to focus more on the United States. Here are the learning objectives for today. We're going to define factors like social determinants of health and health equity and disparities, talk about how social determinants of health contribute to disparities observed both in COVID-19 and in cancer, and how COVID-19 may exacerbate existing cancer health disparities, and then end with some opportunities for improvement. So let's start with some definitions. So social determinants of health are getting, importantly, increasingly attention lately. So the World Health Organization defines them as the conditions in which people are born, grow, live, and work, and age. And the figure on this slide illustrates how socioeconomic and political contexts, including governance, policy, and cultural and societal values, have a role in determining the position of an individual in society. In this model, there are two categories of social determinants, these structural determinants and intermediate determinants. Often we focus on intermediate determinants, which include health behaviors in the health system, but we also must recognize the upstream factors such as socioeconomic position and socioeconomic and political context, which affect health both globally and within the country. And, in terms of health equity and health disparities, I was giving a presentation not long ago and discussing health disparities, and someone asks, shouldn't I be talking about health equity, which is sort of the aspirational goal, as opposed to disparities, the differences. And, I've thought more about it and learned more about it and understand the ways in which we should use a different term. So health equity is the assurance of the conditions of optimal health of all people. Again, it's the aspirational goal, whereas health disparities are what we measure. So I'm an epidemiologist. I measure things like this all the time. It's the differences in incidence, prevalence, mortality, morbidity based on group status, like race, ethnicity, which will be the focus of my talk today, but other factors that are intersectional, like socioeconomic status, sexual orientation, disability, and geographic location. And inequity results when there is systematic and unjust distribution of the social determinants of health. And fundamental cause theory, initially posited by Link and Phelan in the mid-90s, suggests that disparities persist because despite our advances, disadvantaged communities persistently lack resources that enable them to protect and enhance their health. And ultimately, health disparities, the thing that we measure, will be eliminated when health equity, that aspirational goal of fundamental availability of the resources that contribute to health for all, is achieved. And when we're thinking about racial and ethnic health disparities, which I will talk about predominantly today, we have to understand, what is the systems that lead to the unequal distribution of these determinants of health. In this case, as we've been talking about a lot for the past year, are racism and race. So here's a definition from Dr. Kamara Jones, who we had the pleasure of giving a lecture here at MGH in the past year. that racism is a system of power that structures opportunity, assigns value based on the social interpretation of how one looks, which is what race is ultimately. And therefore, it unfairly disadvantages some individuals while equally unfairly advantaging others and sapping the strength of the society. So how do disparities ultimately arise from the interplay of all these factors I just described? I think we can think of it in sort of three main buckets, that they are differences in life opportunities, exposures, and stressors. So the different experiences that result from the unequal distribution of the social determinants of health. It also results in differential access to healthcare, and which includes preventive and curative services. I think often this is the place, particularly elsewhere in the healthcare system, focus on, as well as differences in quality of care. And so with that foundation, we'll think about how these factors have interplayed in the COVID-19 pandemic, and then ultimately in cancer. So I think we're all aware, we've gone through a really incredible, crazy year. If we look at the COVID-19 pandemic here in the United States, as of yesterday, there were over 32 million cases diagnosed, with unfortunately over 500,000 deaths. The maps on the right are showing the spread of COVID-19 across the country over time. The first map is from November 2020. Here, red indicates high-risk counties, with green being areas of lower risk. In November, almost the entire country was in red. We've seen significant improvement here in May, where most of the country is in yellow with increasing areas of green. But as we know, the pandemic is not over, and certainly not globally. We just heard about radiology in India, and the pandemic still rages on in many countries unabated. So if we look here at the data on COVID-19 in the United States, here's showing weekly cases per 100,000 by race ethnicity, going back to last spring through now. We see that different racial ethnic groups have had a different experience in terms of their risk of infection, with green here showing Hispanic Americans who throughout the pandemic have had higher risk of COVID-19 infection. And we've certainly seen something similar here in Massachusetts and at Mass General Hospital in terms of the communities we've served in Chelsea and Revere. There's also been an excess risk among American Indian and Alaska Native populations, with lesser levels among other racial ethnic groups. So that's incidence. If we look at mortality, we see a somewhat different story, with these distinctive waves of both infection and mortality, but also the first wave being showing higher rates of mortality among non-Hispanic Black individuals, shown in the red line. Whereas as we get to the winter peak, the second peak that occurred in the winter, we see the distribution skewing more towards American Indian, Alaska Native, and Hispanic individuals bearing undue burden of COVID-19 mortality. And so there's been lots of work to try and understand the factors that led to these observed differences in risk and mortality between groups. Here's just a couple of headlines from the New York Times, which has had, along with I think the Atlantic, a really excellent series on the COVID-19 pandemic and racial and ethnic disparities, and looking at social inequities. And so, the social determinants of health have certainly played a role in COVID-19, both in terms of access to testing and now vaccination. There were also social and economic factors which led to increased risk of exposure, including greater proportions of essential workers who continued to work throughout the pandemic, often without appropriate protection. Housing situations, including multi-generational housing, and space limitations that limit the ability of individuals to quarantine, reliance on public transit and other factors which lead to greater exposure, just less ability to isolate, and limited access to PPE. There was early on, I think, a lot of discussion about, is there some vulnerability factor, and a lot of discussion about higher prevalence of comorbid conditions. If we think about the model that I showed earlier, the unequal distribution of disease and comorbid conditions like hypertension and diabetes, which were associated with COVID-19 mortality, is a function of the social determinants of health. But several studies have shown that there's similar risk of hospitalization by race among infected patients, as well as similar mortality among individuals that were hospitalized, suggesting that a lot of the difference is really being driven by these access and exposure factors. And so within Massachusetts, here on the left is a panel from a recent publication by our colleagues at Brigham and Women's Hospital, who looked at access to testing within the state of Massachusetts, as well as the city of Boston, according to social vulnerability. So here on these graphs, this first graph is showing socioeconomic vulnerability in the city of Boston, and then the state of Massachusetts, and showing that areas in red are areas of high vulnerability. The second panel shows testing intensity and shows that it's almost the inverse of what we see with respect to social vulnerability, such that testing was highest in the areas of Boston that had low vulnerability. So this is Back Bay and Beacon Hill, whereas this is Dorchester and Mattapan. And this is showing the gap, the testing gap, showing that the gaps in testing are greater in areas with greater vulnerability, like East Boston, Dorchester, and Mattapan. And this is a similar sort of graph that's showing social vulnerability with high vulnerability in the darker blue, low vulnerability in the lighter blue in tertiles, and the normalized distribution of vaccination coverage showing lower vaccination coverage in higher vulnerability communities. So we were interested in investigating racial and ethnic disparities in COVID-19 risk and the role of community level social vulnerability using data from the COVID symptom study. This is a large study using app data led by Dr. Andy Chan here at MGH, as well as investigators at King's College in London and the Zoe Corporation. The study launched in March of 2020. It's available in the United States and the United Kingdom. There's over 3 million people have enrolled and used the app at least once. Most of the enrollees are in the UK, but there are over 200,000 participants in the US. I'm going to focus on our US data today. And so when we looked at our app participants, we found that Black and Hispanic participants were at higher risk of COVID-19 infection. For non-Hispanic Blacks, it was about 47% greater risk and 70% greater risk for Hispanic individuals. We looked at community level deprivation in relationship to COVID-19 exposure and infection. So the deprivation score included census zip code tabulation area level measures of educational attainment, employment, occupation, and residential characteristics. And here we're showing the results. These are relative risks for contact with a person that was known to have COVID-19 or self-reported infection with COVID-19. And we found a dose response relationship such that individuals from more deprived communities had higher risk of contact and infection. And we found that community level deprivation mediated the association between race, ethnicity, and COVID-19 risk, with about 17% of the association mediated in non-Hispanic Black participants and about 6% in Hispanic participants. Of note, these are, again, community level measures. So if we had, individual level measures of social determinants of health, we likely would explain additional variation. All right, so that's COVID-19. So what about COVID-19 and cancer? Let's just start with where we were with cancer prior to the COVID-19 pandemic. So here are cancer mortality rates by sex and race ethnicity in the US. And you'll see that the highest mortality from cancer is among non-Hispanic Black and non-Hispanic Black men and women, with also elevated mortality, particularly relative to incidence for American Indian and Alaska Native populations. And this variation also varies by site of cancer, with Black disparities driven in women by breast cancer, and in men and women for colorectal cancer, and in Black men for prostate and lung. Whereas for American Indian and Alaska Native populations, there's also excess colorectal cancer risk, as well as less common cancers like liver cancer. There also were gaps in screening. Here I'm showing you the proportion of the population that's not up to date with cancer screening by site. And you'll see there's huge gaps for lung cancer across all groups, where a large proportion of the population that's eligible has not been screened, but low rates of colorectal cancer screening. Cervical cancer screening has the lowest proportion of individuals not up to date, but similar to breast cancer, but we do see particular gaps with Asian American populations for breast cancer. So if we go back to what I showed before in terms of where disparities arise from, opportunities, access, and quality of care, just highlight how those are operating in breast cancer, which is an area in which I do a lot of my work. Here's a study that showed that a neighborhood level redlining, which is a system that led to decreased access to housing in certain neighborhoods, basically excluded Black individuals from living in certain neighborhoods due to mortgage lending, and found that living in redlined neighborhoods was significantly more common in non-Hispanic Black women. 80% of the Black women in the study lived in a redlined census tract, and that was associated with higher breast cancer mortality. Racial residential segregation, which is somewhat a function of historical redlining, but other contemporary practices, continues to segregate populations, both in terms of where they live, but where they receive care. Here's a map of Chicago showing differential distribution of population. In blue is Black individuals, yellow is Hispanic individuals, and red is white individuals. You see that they live in distinctly different places, and that where care is located is unequally distributed across these places. So of their 12 Chicago hospitals that have Commission on Cancer designation, only 2 are located in predominantly Black areas. I've done work showing delays in diagnosis, where we found that Hispanic and Black individuals had longer median time to diagnosis after either presenting with symptoms or an abnormal mammogram. And we've also demonstrated that Black women using data from the National Comprehensive Cancer Network are more likely to die from the most treatable forms of breast cancer here, the luminal A tumors. The more deadly forms of breast cancer, triple negative breast cancer, we saw no difference, suggesting that sort of the place where we can do the most to prevent mortality is the place where the gaps are the greatest. And we saw that these differences were driven both by tumor characteristics, but also stage of diagnosis. Delays in diagnosis, which I described earlier, are associated with later stage, differences in body mass index, the predominance of Medicaid insurance and uninsurance among racial and ethnic minorities, as well as comorbid conditions, which we described result from some of these upstream factors as well. And then lastly, the COVID-19 pandemic has really had an impact on cancer screenings. Here's data from EPIC, which showed missed diagnoses for, not missed screenings for breast, colon, and cervical cancer. We did a study here in Massachusetts looking at declines in screening related to COVID-19. As you can see in the spring, as COVID-19 cases were increasing and many institutions and clinics were closed, the rates of screenings declined precipitously. At least in the spring, we didn't see evidence that the decline was different by race ethnicity. We wouldn't expect it to be, right, because it was mainly driven by closures more so than decision making. But it will be important to look as more data becomes available to see how people have returned to screening. But it's really important because there are significant long-term implications. The National Cancer Institute estimates that there will be 10,000 excess deaths from breast and colorectal cancer over the next decade as a result of missed and delayed screenings. And we also have to keep in mind that the COVID-19 pandemic has had serious economic and social consequences. Here I'm focusing just on unemployment and the impact that it has on health insurance. Our system links health insurance to employment, and the layoffs and job loss that occurred as a result of the pandemic has serious consequences in terms of individuals' access to care. So lastly, what can we do? There I think are ways in which we can help people re-engage with care, using telehealth and outpatient care, risk stratified strategies to bring high-risk patients in quickly. I know that the breast team here at MGH is using a risk stratified strategy, helping patients weigh risks and benefits, using decision aids, and really keeping health equity on the forefront. In terms of other interventions that can help, there's a citywide program going on called Translating Research into Practice, being led by Dr. Tracy Battaglia at Boston Medical Center and Jennifer Haas here at MGH, which includes systematic screening and a referral system to identify and address social determinants of health needs among vulnerable patients diagnosed with Boston anywhere in the city. So it's a cross-institution, cross-city approach to try and reduce disparities. And here at MGH, they've tested a same-day breast biopsy program. I showed you delays in diagnosis, and the idea of this program is to offer biopsy to individuals on the same day in which diagnostic examination occurred, so there's no opportunity for delay. And it's shown to reduce disparities, pre-implementation disparities by race and insurance status. So I think that there are opportunities to try and address disparities, to take into account the social determinants of health and address the barriers that they create. And I just want to acknowledge the Klibanski Visiting Scholars Program, my lab, the Symptom App team, and Dr. Epstein, who provided the data on screening in Massachusetts, and end with a favorite quote of mine in relationship to disparities. Knowing is not enough, we must apply. Willing is not enough, we must do. So thank you very much. We'll have a few minutes for questions.
Oh, you're muted,
You're
Louisa.
on mute.
You'd think by now I would know to unmute myself. I was saying thank you both very much for your talks today. Those were excellent. And we do have time for a few questions. So for people in the audience, please do put them in the chat function. We're already getting a few comments that these were outstanding. I'll start off with a question for Dr. Mango. I loved your pictures, first of all, that really sort of showed the work that you were doing. I had that image of that sort of big Phillips truck kind of rolling into, a village or a town. I lived in Kenya for a while. I'm just like thinking how just bizarre and strange that must be. And so I was just curious how you and your colleagues really built trust around this. Not only of the truck, and then you get inside the truck and there's all sorts of like bizarre, medical equipment that probably no one's seen before. So how did you bring people to you and get people?
Yeah, that's a great question. So a lot of work is done before the truck kind of rolling in. So I was involved doing some field work with local social workers, and actually our work centered around visiting the daycare centers in the schools, because that tended to be where women gathered. And so talking to the local leadership about, are they okay with this truck coming here, showing them pictures, explaining the point of the truck, and also just being very clear, screening is, as much as I am very pro breast imaging and pro screening, that's a personal choice to make. And particularly in Nigeria, we've seen some women do not want to be screened because being diagnosed with breast cancer will mean their husband will divorce them. So really eye-opening kind of cultural considerations for women as to whether or not this is something they want in their community. So the places where the truck actually shows up are the places where women have really expressed an interest in being screened and a willingness to follow up with screening results, because obviously a big part of this is making sure that if you find a cancer that you do something about it. So that's also a big consideration.
Great. I have other questions, but I don't know if Dr. Mango or Dr. Warner, you guys have questions for each other as well, giving us an opportunity to kind of crosstalk a little bit.
How do you ensure that individuals get into treatment after you find a cancer in these different locations?
So the only communities we will go to is where the initial work has been done to demonstrate a workflow for that, and that depends on where it is. So for example, some of the communities we went to were what are called slum communities within Chandigarh. So they're not very far geographically from the hospital, but there are many barriers for women to come to get screening. So for example, making sure that we have funding for transportation, social work support, funding to get them treatment. So there are some communities that have said, can the van come to our community and do this health fair? And there's been several where we have not done that because there has not been a way to demonstrate that we'd be able to help the women. Eric, I was wondering with telehealth, I work in our Harlem Center. Memorial Sloan Kettering has a satellite office there, and we've run into a lot of disparities with telehealth in terms of access to technology. Is that something that you've seen as well?
I think I've heard a mixture of both that experience and the opposite experience of, I saw a patient via telehealth that I'm pretty sure would never have come in, that we've been trying to get physically in, and it's just too hard. So I think it's kind of one of these situations where it works well for some people and for the people that it helps bridge barriers, that's fantastic, and let's use it. And then the people for whom it doesn't work, I think there may be, you know, to the extent that we can offer technology solutions to try and bridge the access gap, let's try that. Otherwise, you know, maybe the more traditional approach works better. So I think, you know, I think what some of the things we've learned during COVID-19 is about flexibility, right? And really, how do we allow a system to be flexible and nimble to sort of meet the needs of both, you know, a crazy pandemic ongoing, but also the basic needs of our patients.
Outstanding. I am looking that we're running up against the end of the hour here, but again, those were just outstanding talks. Thank you for bringing our awareness both to the work you're doing globally, Dr. Mango and Dr. Warner, to the disparity work that you're doing that really highlights how much work we really have left to do. And I just a really good combination of talks today. So thank you very much. Thank you for all of our attendees and joining us today and supporting both the Anne Klibanski Scholars and this visiting lecture series. So thank you so much.
Thank you.
Yeah.